schedule that everybody has. Then we also have several of our colleagues online, and we're trying, just so you guys know, we're trying to get the audio set up so you can see, we can hear you without crazy echo in the room. Uh, I plan to give a brief overview of where we are since our last meeting. If you recall, we were here uh, in November during American Heart Association meeting, and we uh, sort of helicopter viewed the project. And so between then and now, we've had several updates that I'd like to share with you. And then we dive into details of the trial design. I also had the uh, luxury of meeting with David Marin twice over the Zoom and get his brain, and Fatima and Alex and Nathan Wong, so they contribute, and David Marin and David Yankelovitz. So the goal is to connect over the next hour with all of your brain, and hopefully within an hour, because some of you guys have to leave, we have a clear picture of what we're after. I also invited Susan Wojcicki Foundation. David Yankelovitz, Nathan, and I had a call with Caitlin from Susan Wojcicki Foundation. You might remember they gave a brief introduction last time. Caitlin and Nadia and their organization, the Susan Wojcicki was the former CEO of YouTube, one of the early team members of Google, and sadly at age around 50, died with lung cancer and had no smoking history of any sort. She left a big hole, both in the tech world and emotionally. And so there's a foundation with her name, and Caitlin and team are moving that mission towards raising awareness. And all, they have a lot of stuff, so I don't know all their research projects, but they will. We invited them as well. So with that introduction, I was trying to get audio set up. Okay. They're asking me to put myself on mute and talk through the microphone. Can you guys hear me online?
Yes.
Okay, perfect.
Yes.
Much better.
Great. Thanks again. So let me go back and credit my colleagues, David Yankelovitz and Claudia Henschke, who collaborated with me, and I collaborated with them. We launched this first conference on integrating early detection of heart disease and lung cancer. This was the first that we tried to bridge these two worlds. Lung cancer screening has its own universe, and we have our own universe. And so this was the first time. And it was on the back of their work for some 20 years, where they report cardiovascular findings in their lung cancer screening very thoroughly. And they are very aggressively pushing for CAC and early detection of atherosclerosis in their group. So we also had the pleasure of having Dr. Fuster and Dr. Harrington both participated in our meeting. And this was the bottom line of that meeting. And that was that this was the past. David and Claudia are credited for leading the field towards lung cancer screening. So they created this for us, the middle. And now we are here. We want to create this comprehensive screening. And for that, we realized that we need to generate the evidence that's required to bring this to mass adoption. So let me just give you a quick update. That was November. Between November and now, some of you are aware, but I'm going to give you a quick update. We've made progress with CMS, trying to get coverage for coronary artery calcium scan imaging. It's a diagnostic test. We have been in back and forth. They sent us this letter a month ago that they're working on it. They needed 60 days. And we're constantly reminding them that 60-day ticket. Then, if you recall, I introduced Project LIFEMAP, low-dose imaging for early multi-disease assessment intervention, LIFEMAP. This is an ARPA-H project that we briefly presented here. This is a joint project between Heart Lung and GE Healthcare. I showed you this briefly last time. This project is ongoing in terms of submission with ARPA-H. The project is basically a robot CT scanner that has zero human involvement, and it does a full chest CT along with all cardiovascular CAC scan and reporting LS. So it's our equivalent of robotaxi in preventive imaging. Very ambitious project. We are asked by ARPA-H to they gave us a green light, and we're about 10, 15 days. April 10 is our deadline to submit the ARPA-H. We broke it down in 3 phases. So you can see the vision. It's a 10-year vision, where by year 3, we will have the first robot at Mount Sinai. Zahi Fayyad and Roxana Merwan are the co-PIs for initial testing on 100 human subjects. And then we go to the next step, and we have a large group of nonprofit and academic institutions involved. So this is a work in progress since November. We also got some progress in terms of bringing opportunistic screening to CAC scans. Here we got FDA approval for reporting all these stuff from a CAC scan. And also now we're waiting for FDA to approve opportunistic detection of lung cancer in CAC scans. Again, CAC scans, coronary artery calcium scan, as the method of choice. So then we have an update on CAC scoring. We introduced, or about to, Agassiz 2.0, which builds on what Arthur Agassiz and colleagues presented some 36 years ago. And in a nutshell, it improves the power of 0. The power of 0 is already great, but Agassiz 2.0, as you can see here, the blue line are individuals with Agassiz 0, current Agassiz 0, CAC 0. When you apply Agassiz 2.0 through AI CAC, you can see how that group is reclassified to upper and lower risk. And we tested it in Mesa, Framingham, and a pooled cohort. Same way, Agassiz 2.0 also works in 1 to 99. That's sort of our Achilles heel in CAC. We don't know. We know what to do with CAC 0. We know what to do with CAC greater than 100. The 1 to 99 is a little gray, and this study showed that significantly that group is reclassified upward or downward using Agassiz 2.0. Then we also applied it to CAC scans in Miami Heart. This is very new data. This is literally 2 days ago, that those people who had CAC 0 in Miami Heart, we applied Agassiz 2.0, and you can see these are CAC 0 with soft plaque or non-calcified plaque. And then you can break them down into 2 groups. The ones that are greater than 0 by Agassiz 2.0 have significantly higher soft plaques. This is another update, and that is gated versus non-gated. So we're crossing lung world and cardiac world, and this is sort of a crosstalk. On the left side is cardiac scan. On the right side is lung scan. These are MESA findings. where it shows that the top quartile in the cardiac is similarly to the non-cardiac or lung scan developed heart failure and atrial fibrillation. Heart failure is further down, atrial fibrillation is up. So that was a quick summary from November, and I'm going to pass on to my colleague, Tony Reeves, who is a professor and computer vision scientist at Cornell. And with him and David and Claudia and others, we've been focusing on identifying lung cancer and predicting. Now, the prediction is a much more ongoing and under development work, but you will hear from him, and you might be surprised that there is a really good connection between CAC and lung cancer. And Michael Blaha published that some time ago. So I'm not going to go into this. We have two papers showing both 15-year outcome and 7-year outcome, 6-year outcome of lung cancer prediction through CAC scans. Tony?
Thank you. Just I'm just going to get the presentation up on the screen. Give me a moment. I need to okay. So I'm going to present here the results of some of our most recent studies. This is really the work of Mohammed Mazafari, who unfortunately cannot be here today. So I'm sort of really presenting his work in this area. And what we're talking about, the fully automated identification of lung cancer in both lung and CAC scans, and we're working both simultaneously. And I'll hopefully show you the difference if there is any. So, excuse me. I don't know what's gone wrong with my presentation here. Yes, I can see that. But I'm missing, anyway. Recent results. Okay, this is the wrong presentation. If I can just take a minute to sort out what on earth happened with this. That's the wrong. Let's try again. My apologies.
Let me check if people can hear you. David, can you hear Tony? Can you guys hear Tony?
Loud and clear. Hearing well, no problem.
I hear him well too.
I'm having a technical issue here.
Okay, I can go back to my slides.
Okay. No, I'm back. I'm back. Yes, I'm sorry. Okay. So lung cancer is most deadly of the cancers. The lungs are visible in cardiac CT images. And one of the things we are addressing now is how to use AI to automatically review CT images for evaluation of lung cancer. So we're going to talk about some research we've done using one of the models that's out there, which is called Sybil, which is an AI publicly available tool that has been trained for lung cancer screening. And we've used it on both CAC scans and regular lung scans, which is what it was originally designed for. And the things we're going to talk about is, things like rule-out screening, lung cancer detection, and lung cancer prediction. Thank you. So you guys already know about cardiac lung cancer relationships from CAC scores, and this is the work by Desire and Blaha and co, showing that CAC scores can predict lung cancer. And we have repeated that using totally AI methods. So rather than do manual scoring now, the AI algorithm goes in and shows for your top quartile, whether it's done by category or by a quantity, then you can predict lung cancer better than other quartiles. If you've got CAC, it's bad for getting lung cancer as well. So these are the studies that I'm reporting on: rule out screening, prediction, evidence that it works, and how it relates to CAC scans, and performance versus AI, comparing clinical risk factors, and we'll just try and cut those very quickly. We're using 4 data sets, 2 data sets for whole lung scans and 2 data sets, as you will recognize, for cardiac lung scans. The AI model is trained to detect cancer in CT scans. You put in a CT scan. This is from the NLST that went on for several years. And in that time, they recorded when a cancer event occurred. And so the training for this was a very basic model: put in a scan and teach one of the outputs to when cancer was occurred. And so we put in, the idea is you put in a new scan, you get a probability, 6 probabilistic outputs. It had a little sparkle in that they put in attention training, so you could also put in the cancer nodules, only the cancer nodules, so it would pay special attention to that. And that gave it a little sparkle, which Morteza really enjoys, and that means that it also shows where it is putting its attention. So here we have both a CAC scan and a lung scan, and it has lit up this region where there's a very large nodule. More interestingly, as in this case here, it was lighting up suspicious areas, and it turns out, this is from the MESA data set, that 4.8 years after the scan, this person was diagnosed with cancer. So I just go through the studies very quickly. The first one was to make it super sensitive. And since it isn't a nodule detector, it's a nodule predictor, we added on a nodule detector. So that identifies all lung lesions that are in the lung that is available in the scan. And then we OR that together with the output for civil, the idea being super sensitive. So maybe we can do a rule out. We can be very confident that some cases don't have cancer. And in the study here, this is showing using Sybil. This is with Monai, the nodule detector. And these columns here correspond to using both together to make it most sensitive. In this case, if we set a threshold so that we consider half the cases here that are true negatives, we find out that the number of false negatives, those that are cancers that we miss, is in the order of 0.04%. Now, I don't know how that performance corresponds to actual radiologists, but I imagine that they'll be very lucky to get down to that kind of scoring rate. So this is just initial results showing that in this, if we could use this in some way, we could not need to read the very detailed reading of those scans to identify tiny nodules in 50% of the cases. We could just rule them out by saying there's no nodules, there's no prediction here, let's move on. Okay, next thing, a risk predictor compared to today's epidemiological models. And the model that we're comparing for now is PLCO. That is a non-imaging model based on all of the patient characteristics that predicts cancer. We compare that with Sybil, which does not know any of these parameters, but just looks at the image. And the outcome is, as you can see here, with PLCO on the left and Sybil on the right, it's doing a better job. and I forget what the numbers are.
Art, I'm not sure if you can hear us, but those of us who are online lost the sound.
I also cannot hear sound. Can anyone hear me?
I can hear you.
Yeah, we can all hear
Okay.
each other, but they can't hear us.
Oh, we can all
and,
hear
we
each
can't
other,
hear
but we
them.
What I'm
I
showing
can't hear
here,
anything going.
top row is ROC, bottom
oh,
row
he's
is
back.
PR,
Okay, it's
AUC.
back.
And you could see that only in one instance is there no significant difference between rating. In all other cases, there's a significant improvement by using the automated imaging over using a standard risk model. In this case, we look now at all the years. We look at, I think this is MESA for over 15 years, and we see that in all those years, the area under the curve for predicting cancer is in the order of, 0.75 or something like that. So this is a consistent positive outcome for multiple years, all this done with the MESA long-term study. How about for CAC scans? So this now is a comparison between MESA on the left and Framingham on the right. And the red line is with lung scans, and the blue line is with CAC scans. And as the CAC scans are only seeing around half the lungs, you would imagine that they would be half as good, would be optimistic. But here we see that the predictions are coming out very comparable. The cohort, and for Framingham, it is not quite so successful, but for the MESA, there's a very heavy overlap. And this is for the 6-year period. Okay, next, how do we compare with radiologists? And the standard rating scheme for radiologists in this country is LUNGRADS, and there is another more advanced model called PanCan, I believe, that's used in Canada and is available to all. And this is how it turns out. So the green line is your LUNGRADS, is today's American-approved radiological reading method. The red line is Sybil, and the blue line is the PanCam. And you can see that Sybil and PanCam seem to come out remarkably similar, and they're both better than LUNGRADS. So again, this fully automated method is highly comparable with the current reading techniques that are used by radiologists for these scans. Finally, comparison here with Sybil and clinical risk factors. This was done in a model by looking at all the patient information that you could use to predict the high-risk pack years, age of the patient, all that kind of emphysema was an additional reported item here, sex, and also if there was radiologist report, if there was a nodule present. So all that was put into a model and would predict lung cancer, compared now to this Sybil AI that's just looking at the scan. It doesn't have any of this information. And this is the outcome now. The AUC here on top is for Sybil. And whether or not you tell with models using just the other factors, they don't come up to scratch. Additional study, I've already covered that. So conclusion, there's an important role for fully automated AI systems to play in lung cancer evaluation for both the lung and CAT scans.
Thanks. Marlon? Okay. Thanks, Tony. I hope you guys online can hear us. If there is an issue, let us know. We are going to now switch to the main entree of this meeting. And as they started serving appetizer, we're going to start the entree here. So the entree is really the trial that we're talking about. So as I said, I had the pleasure of engaging our colleagues' brain over the past few weeks. And here's the latest in this graph. You'll see the proposed study design is a two-arm study where the intervention arm is image-guided therapy. Yep. Oh, to make it larger, yes, sure. Thank you. Let me put it. So this obviously is self-explanatory. I'm going to open it for discussions. There are several points of discussions. One is the primary composite endpoint that we brainstormed about, and then secondary endpoints. So one is related to the outcomes and endpoints. The other one is related to interventions, what exactly the interventions are and who we're targeting based on imaging, image-guided therapy or direction strategy. And then the third one is annual scan in this arm. And that particular topic, David Yankelowitz, radiologist and lung cancer screening pioneer, will weigh in on his part. And then Jim Mulshine from Prevent Cancer Foundation and other colleagues may weigh in on that. So 3 topics. David? It's hard to see.
Mark, hi, did you want me to speak about the lung cancer portion of this now? Hello? Can you hear me?
Through that. Yeah. Can you see, is this better? I put this in different slides after that to go through each one of those. But if the actual presentation, yeah, I can do that. I can bring it up. So this is where we start. We start by saying we want to go down the path of not having to do pooled cohort equation or prevent or Framingham score, all that stuff. Start just like mammography with age. That's it. That's the only inclusion criteria, age. And this proposal is for 50 to 80. Then comes the 2 arms. Obviously, the control arm is the standard of care today. We do whatever we have for primary prevention. This is a primary prevention population, obviously. And then here is the intervention group. The intervention group is based on an initial low-dose CT, LDCT, and then allocating them based on findings. So if we find CAC, what do we do with CAC? If we find enlarged chambers, if we find enlarged aorta, if we find osteoporosis, if we find lung nodules, if we find fatty liver, we find severe emphysema. So those, each one of those, just for the sake of discussion right now, we should just agree that there will be a consensus among experts of what they will be assigned to. But we have consensus for CAC right now. You get CAC If it's greater than 0, you're flagged, and then it's greater than 100 and then 300. So a similar guidelines and recommendations will be put in place for this study. Now, David Marin asked several questions that are practical. I'll go with his questions. For entry to this trial is just 50 to 80. Yeah, just 50 to 80. We initially had it in November 40, and David argued that we have a better chance, and we all agreed that let's just start with 50 to 80. So 50 to 80 entry, no other criteria, and exclusion criteria are just, bunch. They cannot have any kind of prior history of cardiovascular disease, lung cancer, or COPD, and so on. Then comes here, the follow-up is 5-year, and then we have a 5-year extended observation. This part, composite primary endpoint, was the topic of discussions. And so you see here what we concluded as the most logical composite index where we have a chance to show, and they make a difference. Obviously, we all know MACE is the most dominant part of the outcomes that we would expect. All-cause mortality, hospitalization for heart failure, PAD or major adverse limb events, the percentage of late-stage lung cancer, stage 3 and 4, COPD hospitalization, and then hip and vertebral fracture. Now, we don't anticipate much coming out of osteoporosis or probably COPD as well, but these are known endpoints that we've identified. We discussed the idea that if you put diagnosis of heart failure or diagnosis of AFib by imaging and flagging people to go get checked for heart failure and AFib, we kind of prompt them to be diagnosed. And therefore, that would be counterproductive for what we're trying to demonstrate. So we put things that have meaningful impact. Hospitalization of heart failure is what makes a difference. So is for COPD hospitalization and exacerbation. The secondary endpoint would be just what we know: CVD mortality, lung cancer mortality, COPD, fracture, hepatic events, which I'm going to invite our liver expert, Andrea, to weigh in. We don't really anticipate a lot of value by focusing on liver events. Most of liver events related to cardiovascular or cardiometabolic that we already capture here. So with that overview, the main purpose of today's meeting is the discussion of people in the room. Iran, we plan to put down whatever you guys discuss and write it up and circulate after the meeting. So I'm going to invite on that side, so starting from Paul Ricker, and then go David Marin, Dan Berman, Martha, and Kuhn to hear your thoughts. Marlon, pass.
I don't know how I got so lucky to go first. I did have a fundamental question, which is, could you describe the control arm for me? Because I don't quite understand what we're comparing yet.
The control arm is the status quo. What we have for lung cancer screening today is 50-year and older, year pack.
Can anyone hear this?
Nope.
But your
Nope.
main outcome here is cardiovascular.
Yes.
I don't know that Mort's using his mic.
Sorry, guys. Can you hear me?
Yep.
No.
Okay. So
No, no,
Paul Ricker asked the first question. He said, I'm not clear what the control arm is. So you mean what they're getting in terms of risk assessment? It's the risk factors, prevent or PCE. We evaluate the risk and we treat them according to the latest guidelines. Usual care, yes.
But more.
We're not treating them. Yes, we're just giving their data and direct them to go to get care. So, Paul, let's poke hole in there.
Well, among, okay.
No, Paul.
It's only partly a joke, right? Funny the way it was said. Trying to wrap my head around
Yeah, let's.
what
Can
the
you?
IRB would say about this proposal.
You
And
are
I don't-
the IRB right now.
My
Yeah.
IRB is going to say no
No, and that's because
because standard of care and quality care are two different things in an ethical trial, right? You can't just this is the classic issue. You can't go to sub-Saharan Africa to test something because that's not, just because they can't get good care doesn't mean you can ethically do it. So this is an ethical 101 problem so far as I'm concerned. And I'm trying to understand how you're going to get around that in a massive screening study. And you must have thought about it. So I'm trying to understand.
So more.
yeah. Sorry, we're gonna move the microphone around.
More to that end, in the sample size calculation, did you take into account some people in the control arm are going to be eligible for lung cancer screening and standard of care and avail themselves of that?
Yes.
Yes.
Yes, the
Right,
answer is yes. That
I see.
is included. Those people will get a lung cancer screening according to the standard of care today. I think Paul Ritker brought up a key question, is that what does the control arm get? So this is up for discussion here. That's why we're here. So I had this discussion with David, and one thought was that we provide a virtual care clinic that the other group gets, and they would be consulted for risk factor-based assessment and recommending what they need to get according to their risk factors. And a virtual care clinic that handles the control arm is different than virtual care contractor that handles the intervention arm. So 2 virtual care clinic will be contracted to implement, but the one that is in the control arm has no imaging guidance. It's only risk factor based, but they also give people the same, recommendation that you should go, whatever, cholesterol, blood pressure, weight, all of the things. So that was the sort of overarching proposal, that we get a virtual clinic for intervention arm. The intervention arm clinician for the virtual clinic are directed to treat and manage according to imaging finding, whereas the control arm also get a virtual health clinic, but they don't get any imaging. Yeah, please yes, please talk through microphone.
But they would be actually given standard guideline recommendations
Yes.
to follow.
That's right.
Okay, so that might be.
Yeah.
So what are the exclusion criteria? How would, let's say in the control arm, patient gets some study by himself, how we are going to control that, he can fall out of that, whether he got a study from by himself, how we are going to control all that?
Okay, so if your question is about the intervention arm, we have a plan process in place that they get the app, they enroll, they go get the scan, they get engaged. So everything is managed through the app for the.
Some kind of study by themselves.
Yes, the chances are some of them they go get in. We have to accept that, and that would be part of the.
So they will fall off the control arm, or they will be included in the intervention arm. Then.
Well, if they act on the imaging, I guess logically they would need to be excluded, but that's part of the discussion. We've not had this trial yet, so in any trial there is a crossover. So we would have to address that the same standard that you have in any other trial.
Because if you're going to make two virtual clinics, how they are going to communicate with each other,
They wouldn't communicate. So if we were to do a virtual clinic for the control arm, that virtual clinic is contracted and trained certain way. The virtual clinic that manages the intervention arm will be guided, treated. Basically, they have to have different level of education to get up to speed. But your question about crossover is a valid concern that we have to address. Martha?
What if the usual care arm was something like the Kaiser Clinic or something where you are able to track all hospitalizations, et cetera, with that population? But then you see what usual care really is. Do they use the prevent risk score? Do they not use it? How frequently do they get referred for a calcium score or otherwise? Like, would that be an option?
So I think what Paul, you should voice your concern, but basically what he's saying is if we leave these people on their own and they're not being, attended to and so on, we're not really comparing imaging with, we're comparing imaging plus some other things there. That's what you're saying, right?
It'd be nice to know from a population biologist or statistician, what proportion of people on the left-hand side are going to be on a statin if they're appropriately taken care of. That's the first thing you need to know. Because do you think you're going to actually beat a statin on the right-hand side or not? And that's a challenge to you.
Yep.
But if the number on the left is 50, 60, 70%, I think the chance of winning this trial is extremely low.
Look.
If the number on the left is 5, 10, or 15%, then it might be very high. But I can't quite tell. It just says adults 50 to 80. That's all it says. And I don't know what proportion of those people.
I think we need to talk more about recruitment and entry criterion.
Yeah. So Andrea, I'm going to invite you to weigh in. So basically, and there are a lot of points to go around. So Martha is saying, if you just compare with usual care, if usual care is a big HMO like Kaiser, you evaluate whether they adhere to prevent or all those information. Here, I think Paul is saying that the control arm, if they are getting a statin and their statin percentage of statin user is 30 or 40%, it's hard to beat that. But the point is, we're comparing with the status quo. Status quo, what is the percentage of people in primary prevention that are getting a statin? I think less than 10%. But in primary prevention, it's less than 10%.
So once again, I want to make sure I'm clear, and maybe I'm not being clear. It's extremely challenging, if not borderline unethical, depending on who your IRB is, to do a trial on the assumption of poor care in one arm than the other. It's not that it's not true. We all can acknowledge care is substandard. But in a randomized trial, one of the fundamental ethical issues is you're supposed to actually say, that's not what we do. We have to have good care versus new thing. You really can't compare your new thing to bad care. And if you did do new thing to bad care, you're not going to convince anybody anyway. So you don't want to do that in the first place. Because if the editorial says, well, compared to really bad care, this thing works, no one's going to pay for your thing. It has to be compared to quality care, right? That's why in a randomized drug trial, we add on top of contemporary therapy. We don't add on top of 1950s therapy, right? So that's a fundamental clinical trials issue for me, trying to understand. That's why I'm asking, who's going to be in this and what is the left-hand side likely to get? Because then you can do your power calculation, try to understand what will the right-hand side potentially get more of, and is this exercise a futile exercise, which I wouldn't recommend doing, or could it actually win?
Totally
right?
get it. What's the problem of this group, let's say the control arm, being a virtual clinic similar to the right intervention arm, but doesn't have imaging guiding? It's just pure risk factor based. You do a consultation and recommend treatment based on the risk factors, and they just follow the same way. They don't have annual CT scan. This arm does. They don't have recommendation based on finding imaging. This arm does. But it's not a poor care. It's just a standard of care. It's a virtual clinic, gets engaged, has the patient, with their interview, with their consultation, and maybe with guideline based, yes, etc.
Yeah, but more, Jim Molstein, this control arm today, 50,000 people, if I don't know, most of them will be eligible for lung cancer screening. If 20% of them get it, according to what currently happens in the community, that's not a crossover.
We can't quite hear you well. Can you repeat your question?
Yeah. Mort, can you hear me better now?
Yes, we can hear you.
I'm just saying there's not a crossover, there's a contamination, because if 20% today, and maybe an increasing fraction through the duration of the 8 or 10 years it's going to take to do the trial, get lung cancer screening, they're functionally going to get a calcium study, and they're going to erode the power of the comparison in a potentially a very significant way. And so the question is, should you use a classical trial design like this, or should you adopt, I think as others were suggesting, some kind of pragmatic design where you take advantage of the care as it's delivered in one pattern versus the other?
Thanks, Jim. So we're going down the discussion part. I think we want to address that concern that you have, that whether the other arm getting lung cancer screening and diluting the effect comes right after this. So let's go through this. First question, is this trial designed in an unfair way that the control arm is neglected and gets substandard care and therefore it can't pass the IRB? I think Paul opened our eyes to it, and I think the answer is no. We want this group, the control arm, to get a virtual care consultation and a regular standard risk factor-based recommendation for treatment and move on. But they don't get imaging. They don't get recommendation based on imaging. They don't get annual scan. They don't get those kind of follow-up. So, Paul, do you have anything to add here in this section? Yeah,
Can you hear me?
Okay, so David, let's go to David. Oh gosh, I'm sorry, Kim. I don't know why. Marlon, did you mute people? Kim,
do you hear me at all? Can't hear me?
We can hear you inside.
Yeah, we can hear you, Kim.
I can hear you.
Oh, okay. So yeah, I just wanted to sort of reiterate what Paul was saying, but it just sort of a different light, the health equity issue. We do have underserved populations, and they're underserved for a lot of reasons, poor access. And, we struggle, I hate to say this out loud, but we struggle getting guideline implementations in a lot of places outside of major universities, just being honest. And so, it's really great to say that we want to be inclusive of diverse ethnic and socioeconomic groups, but we want to make sure that we're not somehow overpopulating the people we have to make sure that the people who are getting good care, and that's going to be a very difficult thing to do. Language appropriate, equitable access. There are things about that control group that are going to be hard that, as Paul was saying, I'm not sure that we want to compare unless you have something like Kaiser, where someone is going to follow the guidelines. And so I think Pat was saying the same thing. If there's someone's eligible for a low dose CT or a coronary calcium score, would you deny it? Of course not. And so and as you said, you'll have to take care of some of these people as crossovers and maybe even analyze them separately. But trying to prove that what you're doing is better than guideline directed care will be challenging. I bet it is, but we've got to be very careful on how the control group is treated.
Thanks, Kim. I think Paul brought an important point. I think we have to just make that very clear up front. This trial is not going to be designed just in a way that is favoring the MD. It's designed to show a standard of care which requires consultation, requires recommendation according to risk factor-based guideline and treatment strategies versus the imaging base. So I think we got that point, but I want to go down the line. David?
I just add that the standard of care is a moving target. I mean, the AHA decided to catch up with Europe in the lipid guidelines after 5 or 6 years. And during the design and the conduct of this study, PCSK9 antibodies are going to be generic or they're going to be biosimilars. There's going to be drop-ins of effective medications. So you have to bake into the design the drop-ins and the excess increase and the guidelines changing towards more stringent.
They added calcium scoring to that. So that's a good point. The status quo is a moving target. That's what Peter Libby is pointing out. David, let's hear your thoughts.
Just building on all that's been said already about the control group, I think the ideal but very ambitious and may not be feasible design would be to have this virtual clinic would be the same for both groups. You were talking about having one virtual clinic for one group and a different virtual clinic for...
It would be the same in terms of structure, but one is guided to do risk factor based, the other one is trained to do imaging based.
Right.
But yeah,
so then your
virtual clinic.
Okay. Yeah. So I think that would be the ideal, but we're talking about 100,000 people, we think. I don't know a virtual clinic that can do that.
Yeah, there are virtual clinics that have more than 200,000 customers, clients. It's just we have to pay them for that.
All right.
But it all comes down to the infrastructure, the app, the connectivity, all that stuff. But I think what I meant to separate virtual clinics is that one, we have to educate them, the imaging part and repeat and all that stuff, especially if we go down the path of annual CT scan with David. But
okay,
please go ahead.
Yeah, so maybe I'll just introduce some of the topics that I think would be really good to try to get through. One is this age group is great, but ascertaining events, especially non-fatal events, is going to be challenging, and everything costs money. So one idea to bounce around is limiting this to Medicare beneficiaries so that there are Medicare claims data that you can use for event ascertainment. So that's one issue. Another is, what's the intervention? That's a big topic, and you had a list of PCSK9 inhibitors, GLP-1 receptor agonists, SGLT2 inhibitors, the treatment for osteoporosis, on and on. And I don't know about, well, we should also have a discussion about how is that going to be delivered? What are the criteria for those? Yeah, there's the list. That's a lot. And
we lost the sound, Mort.
So did you hear David Marin's point? So David basically saying maybe we should start with Medicare beneficiary only because the assertion of their events and perhaps payment for their treatment is easier. I think that's a very practical point, but it all comes down if we're able to get funding for the whole thing. If we are, then we can go that. So that's one cost aspect. The other point David's saying is, what are the treatment? As I said, we won't be able to address that question accurately here, but we know that imaging will pick a certain population that are considered high risk, and we can tighten the treatment and tailor it to the severity of disease. And out of all of these, calcium score, we have a common agreement on what is the detection criteria and what is the severity and how to tighten. But the other ones, we have to work on it. We will have to, we had one hypothesis is that people with borderline hypertension, they're not controlled, but they have enlarged chambers or LVH, should get more intensive therapy or double down on if they have. So those are things we have to address later. But let's just start with CAC.
But I wanted everybody to see this list and think about how this intervention would be delivered through the virtual clinic. How's it going to be paid for? I know that these are practical questions, but at the end of the day, to do a clinical trial, you need to have solutions to this kind of thing.
Yeah, I think David made his point very well. So we will discuss this. As I said, there are a few of these are well known, like osteoporosis. We don't need to develop new guidelines. Your Z-score is below minus 2.5. You go down this path and so on. CAC, we have that. There are some recommendation for GLP-1 for fatty liver. So we will have to try to hide behind existing guidelines and not invent until we have to. Thanks, David. Let's go to Dan Berman.
As I told you before, Mort, you're never short on. No one accused you of not being ambitious in everything you do. Just to these, I'm going to make small points. One is you're talking about, again, back to the usual care. We didn't mention knowing what your LDL is. To think that people go, if they're under the care of a doctor, they should know what their LDL is. And that I think that a baseline, as we're trying to do with CMS, it comes in as a diagnostic test after a baseline, but the baselines are going to include blood testing. And I would wonder whether that wouldn't be part of what the usual care would have. The other comment is just in terms of these outcomes in the virtual care clinic is this like we did in the Eisner, is this a one-time deal? You get a scan and then the clinic tells you should be very aggressive with your treatment and then forget it. So it's now just back in the patient's hand or not.
Or not. So Dan's, I'm going to just start with the end of your point. Dan's question is this like Eisner trial Dan and colleagues ran? It's just one-time assessment and show you the image and scare you or whatever, and then you go follow whatever. So the answer is no. This virtual care clinic is meant to be engaged with the patients, and annual scan, I'm going to go to David Yankelowitz in a little bit. Annual scan will make them part of this repeat, so they will have to come back for evaluation.
Same thing in the usual care.
Yes.
Sorry to be going backwards on the table, but let's stay with this idea there's a virtual care advisor. They're going to say you should go get a PCSK9 inhibitor. Who's going to write the prescription and give it to them? I mean, I can't figure out how that's going to happen. I mean, if we had a socialized healthcare country doing this might be feasible, where things happen. But in the United States, giving someone advice, it's a far cry from delivering care, right? Someone has to write the prescription, fill it, pay for it. And I'm not hearing who's going to write the prescription, fill it, or pay for it. I'm hearing some virtual clinic's going to say, hey, you should be on this. And then what happens?
Yeah, I can tell you, we will pay the treatment is paid by both in both arms by the trial. We can't just pay the intervention arm and not pay the treatment on the other side. And David's point with Medicare is that both will pay by Medicare if you go to the Medicare beneficiary target. But the initial proposal here was we get funding from pharma for whatever is the according to, but we don't have PCSK9 for primary prevention today as a routine. So we wouldn't be there. But statins for sure, and we have to pay for it. The same we're paying for this group.
I can't imagine that pharma would be behind treating both sides and hoping for a better outcome in the intervention group. Unless there's a real difference in the treatments because of the imaging. I mean, that's the hypothesis.
That's right. And that is. So if PCSK9 is recommended, Bob Kloner and others published, Matt Budoff, that if you have severe atherosclerosis, that group benefits from PCSK9. So yes.
And I was just going to respond to Paul about the virtual clinic. What we're doing in Transform is we have this virtual cardiology group, Heartbeat Health, that has representation in every state of the union, and they write the prescription. And if there was something similar, then it's feasible to do that with this, just writing a prescription. Who's going to pay for it, and how is the drugs going to be distributed? These are practical issues that need to be resolved. In Transform, some of the drugs are paid for by pharma, others by the sponsor, and others by private insurance.
And someone has to pay for that same care in the usual care arm. Someone has to write the prescriptions, and some group is going to be taking over to do the same thing in the usual care with the guideline-directed medical therapy.
With this proposed
has to be,
trial.
yeah.
Well, I guess my just comments are, if usual care, for example, is the prevent score, some people are going to get a calcium score, or they're not going to be allowed to have a calcium score. And if they get a calcium score, do they get dumped out of the trial, or do we keep them in that same pathway? Do they remain in usual care? I think the other point about Medicare age is a good idea, but I think the problem with that is then we miss younger people that we really want to figure out about prevention. And so I think that, to me, that's a missed opportunity if we just go to Medicare age. And I had the same question about the annual visit in the usual care arm, but I heard that.
Thanks. So Mark, I'm going to go, by the way, I just noticed people put questions in the chat room. So please hold on. I'm going to come to you, ask you, see Dawn and Kim. So there are some questions there. So I think he brought that question before, and you're elaborating that in the, and Peter Libby said the standard of care is moving target. If suddenly everybody gets CAC in the control arm, obviously we can't have them. It has to be moved out to, otherwise we can't do this trial. Whether that could happen, we'll have to discuss. I doubt it would be a standard of care that in the regular arm, everybody go. But there are some people who are going to go get CAC, and we'll have to have an answer for that.
Do the guidelines work or do they not work? You know, do you just need to go for that? You don't have to calculate this risk score. So, I mean, I actually personally think it's okay. I mean, that some people get it, but because you are following the guideline.
Yeah. Yeah, I think so. I'll just leave this question for everybody to chew on, and later we come to a conclusion. But I think what was brought up by Peter Levy and now Marta and Dan is that the control arm is going to get some of the imaging, and we'll have to have a plan for it. So with that, I'm going to go to Koen. Koen?
Just to clarify, I mean, you said annual follow-up. Is that including imaging or just clinical follow-up, just observation?
For the control group is just consultation, but for the intervention, we have David Yankelowitz who's going to argue in favor of annual scan. We had initial one scan and then repeat the scan based on the first scan. If you're high risk by nodule or other things, you get repeated scan. He's making a case, we'll hear from him, but yes, the control group gets just consultation.
Okay, I was just wondering what the purpose of the repeat scan was for. I mean, for calcium, it's a little bit harder argument to make, but maybe for the nodules, that makes sense. And then the other things like the negative effects of screening. I think to what degree do we include that, like unnecessary procedures, complications, and things like that, and cost.
Yeah, so that all comes in the secondary endpoint, cost effectiveness. I think that was also in our meeting in November. Paul brought it up. All the unnecessary downstream testing, whatever we call it, unnecessary, we'll have to define it, but has to be weighed in. And the net effect is what we're looking at. So that definitely we'll be putting that in. So thanks, Koen. I'm going to go around the room here. Peter Levy.
Well, when you're imaging, this is relevant to what people were just saying. You're going to have incidental-omas.
Yeah.
And incidental-omas are going to have consequences. And it's in the low double digits of imaging studies will show an incidental finding which causes concern, worry, follow-on testing, complications, expense. So I think you open Pandora's box.
But if we are scientifically evaluating that, we have to evaluate it, right? Otherwise, we'll just leave it open for people practice without evidence. So if we do that and we find that we actually cause harm more, then we'll stop talking like that. So I think that's the foundation of what we're here. We want to find the truth. And I think this is a warning that, so David Yankelowitz is leading this thing, annual scan, because that's their job. They do every year for lung cancer screening, and they do all kind of things. So whether really this whatever expected downstream testing, diagnostic procedures outweigh all the benefit is something that we'll have to go through. So I think we take your point, Peter, on that evaluating downstream, whatever is coming from this imaging should be a metric that we're measuring. And so we'll have to go through it. Please go ahead.
So I'm Logan Bhaskaran from Singapore. So I think this is interesting, but there are a few things to address in the logistical and practical application of this. So one is obviously, everyone's in the room's mentioned it already. The chances of picking up disease is not that high. That's one. Martha already mentioned that the control arm may have imaging, for example, a calcium score. Peter Libby already mentioned that guidelines will shift. So during the process of this, there will be new guidelines which entail new imaging because we're covering so many diseases here. But also in the actual intervention arm, from when someone is eligible for recruitment to when someone is actually going to have a scan, they may have an intervening scan already in between. And after they're recruited, they're not confined to this trial. They're still within a healthcare system. So they may undergo other similar scans as well. And what's going to stop them from getting an ultrasound of the abdomen for their liver, fatty liver, or actual cardiac-gated CT scan? So what will be the dropout rate from that, or do they get dropped out if that happens?
Yeah, I think you're echoing what was discussed now, and very clear now that we will have this problem, that the control arm is going to get some kind of imaging. and we'll have to address that. So that's a key.
But even in the intervention arm.
In the intervention arm, they just follow the intervention. So if they get additional other imaging unrelated, that would not be counted here. Right now, we're putting them through a regimen of annual scan, which dictates certain things based on those scans.
But when they get that intervening scan, which is not part of the actual intervention here, it will affect their treatment as well.
Yeah, that's in every trial. So patients get certain other things. We'll just have to address them the same way. Right now, our focus is on primary prevention of some of the key elements, and we're just going to target the treatment towards those. Thank you. There are several questions in the chat room. Let me quickly go online. Let me start with Don Lloyd. Don, are you there?
I am here. I think largely, the things that I was raising have been addressed by Paul and David. I think that you have to be careful that, we know that people who get the group that gets more statins will do better, right? And so you can't deliver the statins more intensively to one group to whom it's prescribed than the other group. What you're looking for is a differential prescription rate, not a differential adherence rate once that prescription is made. So you have to just be careful that you're not overwhelming the intervention group and underwhelming the control group. And I think, again, those points have largely been made.
Thanks. So let me ask you a question, Don. What do you think is the percentage of a statin in control arm? I'm guessing about 10% in primary prevention. And so in the imaging, you get a lot more. And so that's our...
Yeah, but that has to be the only difference, right? You can't then, bother the people in the intervention arm every 3 months to say, are you taking your statin, and not bother the other group that's been prescribed a statin, because that's then changing the conditions.
Yeah, I think we discussed that with David Mayer a couple of weeks ago. If that group would get the same kind of reminders, the same kind of virtual care follow-up, it just doesn't get imaging, which would drive them to go do certain things. So thanks, Don. I'm going to jump to Ron. Ron, can you get the microphone?
Yeah, no, this is a great discussion. I would say that in usual care, it really should be guidelines, and we do have a new guideline that came out a week or two ago. And in the guideline, imaging will happen, but it's optional. It's not imaging everyone. And I think that's okay. You have to allow some imaging. And of course, the imaging in the guideline is just a calcium score. And the imaging in the intervention here is fancy and has a bunch of other elements. So there's a difference there. So I think that's kind of the key thing. But then going back to Paul's point, in usual care, even if you just say, here's the guidelines, follow the guidelines, that might not be enough to really have equipoise. So I think one idea is which also will be kind of a carrot for recruitment, is to say, if you get into the trial, everyone gets a free LDL, CRP, and lipoprotein A, and say you have those labs, you can take them to your physician. If you don't want to take them to your physician, you can have a virtual visit as optional. I think some studies are doing that. Not everybody likes to have a virtual visit. We've seen this in Transform, for example. Some people don't like that. Some people like that. So that's a nice optional thing to have. But building up some free labs and some pathway into usual care, I think will be important. And I think it will address this issue that Paul mentioned.
Yeah, how do you answer Paul's concern that usual care, if you just leave it as whatever they do, you're subjecting to poor care?
I think the fact that you give information both to patients and their physicians about here's what usual care should be in this trial, and that you also sponsor some labs, the 3 labs, LPA, CRP, and LDL. I think that kind of means that they're now actually more aggressive than usual care because you're getting labs.
Free lab.
Yeah, so I think that, in my mind, that would address that.
Oram?
Hey, good evening, everyone.
Yeah, they can hear you.
Yeah, this is, I would say, a very intriguing trial design. I was much more on Can you go back on the slide where the management intervention list was?
Yep. This is, of course, just for.
No, I think so. This is extensive. And again, just from a calcium standpoint, of course. So the percentile versus absolute is an interesting concept that we need to understand. The percentile is more for a lifetime, whereas the absolutes are going to dictate the event rates within the 5 plus minus years that you're going to have. So I see here where your LDL goals are less than 50 if your calcium is more than 75th percentile. So just consider that for a 60-year-old woman. Now it's great for women, they'll be treated very intensely because all you need is a calcium score of 16.
That's right.
To reach there. Whereas the same age men, you need to, if they have a calcium score of 125, you will not be treating them as intentionally. And for a young woman, 55, all you need is a calcium score of 1 to try to get their LDL below 50. But for a male, it'd be around 50 to 60. So I'm just saying, thinking around that the absolute, at least for the calcium piece, the targets in a short clinical trial may be much more well served if you're thinking about absolute scores rather than the percentile. But hey, of course, the concept I totally understand. Percentile for your age, treat early, as low as possible, long term. But for the clinical trial, maybe the absolutes may be a better.
Yeah, I think, well, your point well taken. We will definitely put that. This was just high level, just to discuss. I'm going to go online to David Yankelevich. David, are you there? And Andre, I'm going to come to you after that to hear your thought. David, so
yes,
one key, I don't know, I can't see you.
Sorry.
The key part, what are the key parts related to? Okay, yes, there you go. So if the intervention arm is only one scan, and the guidelines is now recommending calcium scoring, and people start picking up. So one of the legitimate question is that it's going to be very similar. Your idea makes it very different because you're saying one scan every year, ultra low dose, and we talked about the 5 scans together, the total dose is less than 1 CCTA. So you got CCTA IRB approval for Transform, so we might be able to get to 5 scans. So David, let's hear your thoughts. Make your case, please.
Sure. So lung screening is certainly a bit different than the calcium score and the rationale. In lung screening, we're pretty comfortable with the idea that people who meet certain eligibility criteria should be screened every year, and there's reasonably strong evidence that there's a benefit to that. However, we're sort of so people outside the guidelines get no screening, right? People within the guidelines get annual screening. People outside the guidelines don't get any screening. However, there is just increasing recognition that lung cancer is occurring outside the guidelines more commonly than within the guidelines. And that trend is increasing every year. So right now, a good 25% of lung cancers are occurring in people that are never smokers. And a little bit more than 25% are people that were smokers, but are already outside the guidelines. Either they smoked not enough packs or they quit long enough ago. So we have this very large group and growing of people that are outside the guidelines. And the question now is, how do we identify these people? What are the risk factors that we should be looking for, that we should start screening these people? So there are things like secondhand smoke, for example. There's radon exposure, there's family history, and a host of other risk factors that we believe would be very useful. So in a study like this, we have the opportunity to start looking at all of that. We can start collecting all of this information in some detail. And the only way we're going to really learn about this and start to understand it is if we screen more than 1 year. If we screen just 1 year, we won't find many cancers because these are going to be a lower risk population. There's no question about that. They'll be lower risk, so we'll find fewer numbers of cancers. What we have to start really learning about is, can we predict the rate of cancers based on these other risk factors? Because right now that's very poor. We also need to be confident that those lung cancers that we find in these low risk populations behave in the same way as they do in the higher risk population. So these are the kind of the two of the main questions that I think we want to answer. And potentially with a study like this, I think we'll be able to get at that answer. If we just do one round of screening, the first round tends to give you a slightly different type of cancer. You tend to get the slower growers, the so-called length biased kind of cases where you capture in the baseline round the slow growth. So you really want to get annual rounds to start really understanding the aggressive nature of the cancer. And so you need at least several annual rounds before you collect enough. I think that we have a good chance in a study like this, even with the fewer number of cancers, because of the size of it, to get a lung cancer, potentially a lung cancer mortality evidence. We'll probably get around 300 lung cancers, I would guesstimate, in the screening arm that are screen detected compared to the control arm. And I think we'll have a good chance of getting a true evidence of a mortality reduction in the traditional way. But at the very least, we'll get very strong secondary endpoints like reduction in late stage cancer, which, since we already know that lung cancer reduces mortality, that by itself would be a great endpoint for these lower risk populations. So for the higher risk populations, I agree with whoever had said it before. We have to make sure that those people in the control arm that are eligible for lung screening are encouraged to get lung screening. No question about it. But, that's easy to manage in a trial like this. You treat it, kind of like as contamination. In any trial, in the NLST, any study like that, the control arm always, you have to account for people in the control arm getting CT scans. So this is treated the exact same way, just like the people in the screening arm that don't get it, that's a lack of compliance. So these are pretty standard. So I think the amount of information we'll get on lung cancer if we do this will be enormous. This is the hottest area in lung cancer now. Who to expand the guidelines to? Lung cancer in never smokers is already the 8th ranked cause of cancer death. And if you combine that with smokers who quit or are outside the guidelines but were smokers, it's way more than the 8th. So I think we will learn a tremendous amount here about other risk factors. We'll also have a spectacular database to develop what I would consider a very strong database to do true risk prediction. So I think all of the things that come out of this are very powerful. I think we do need to do multiple rounds. How you'll use that for cardiac, I'm sure our cardiac imagers will understand that there's a lot you can do with repeat scans in terms of the change in calcium over time and that sort of thing. So but for the lung cancer aspect of it, I think without question, if we want to answer the serious questions about lung cancer, and the serious question is the low risk population, which the Wajcicki Foundation understands full well how important that is. This is the way we'll get those kind of cases.
Thanks,
So
David.
that's my short point.
I think David made the point, and I highlighted this section. In cardiology, we've been complaining about risk factors and their poor predictive power or whatever. We started pitching at Framingham score years ago, and all these advancements that have been made in prevent is now the best in class. But in lung cancer, it's just terrible. So 70% of patients who were diagnosed with lung cancer, this is a JAMA paper last year, would not qualify for lung cancer screening. 70% of people who were diagnosed. So that's what I think David's point is, and we will just
and it's increasing.
And it's increasing, yes. And so Wajcicki Foundation, that Susan was just a classic example of these female, middle age, and boom, out of nowhere, lung cancer, stage 3 and 4, and there's nothing we can do about it. So what David is saying, if we're paving the path for preventive medicine of future, and we're doing a trial or research, we should do this annual. And if at the end of 5 years we find out that you didn't need it. You just needed 2, then you'll be able to conclude from data. But if you don't have the data, you won't be able to ascertain scientifically. So I'm going to switch to Andrea. Andrea has both methodology question, also she's a liver specialist and has thoughts to share. Andrea?
So great to be with you all. I just wanted to first touch base on liver steatosis as an incidental finding. I think it's really simple what we would do if we want to follow practice guidelines. Both the American Association for the Study of Liver Disease and the European Society for the Study of Liver Disease have clear recommendations about what to do when you have steatosis as an incidental finding. So I think we should just propose to follow their guidelines. What the guidelines say is that the next step is to do a test that estimates the likelihood that the person has fibrosis. It's a very simple test. You need AST, ALT, platelets, and age. And then based on that score, which is called the FIB-4 score, if it's below a certain threshold, it's just repeat in a couple of years. If it's over 2.7, the recommendation is immediate referral to hepatology. And if it's intermediate and you're a primary care doc, you would either send for transient elastography, or there's a second type of blood test that you could do. So my thought would be the simplest thing is to definitely not include liver endpoints like cirrhosis or decompensation, but just to say that we will be detecting, we have the ability to detect moderate to severe steatosis, which I emphasize, moderate to severe steatosis is not worse prognostically than mild steatosis. And in a CT scan, you cannot detect mild steatosis, but we can detect moderate to severe, and then just to include in the report what the guidelines are. That would be my recommendation for how to deal with the liver, and I can easily, send documentation of the guidelines and what the steps are for that. But kind of interfacing with David's point and some of the other points, I feel like what we're going to have to do is some pretty fancy modeling in this trial, because I feel like we have a lot of things that we aspire to show, but I just don't know if the expected number of events are going to support doing these things. And so I think we, first of all, need to talk more about who we want to enroll in the trial. Like the whole power calculation is going to be so dependent on the population that's enrolled. So I don't think we can even begin to model the expected number of events, whether they're cardiovascular events or whether they're lung cancer events, until we have a better idea of the patient population. And we really haven't talked about do we want to try to enroll a representative population over the age span that we're enrolling? Do we want it to be just open recruitment, which I think is an approach that really opens the opportunity for some fairly serious biases? We've done community-based screening, for example, for liver disease. So we just go out into a community and we essentially put up a tent and we say we're here to screen for liver disease and explain what we're doing. And what we find is that overwhelmingly, the people who come in for screening are people who already know they have liver disease. So it's a very, this self-recruitment concept in our experience is a very inappropriate way to get a population that's representative of the larger population. And of course, you also have a different problem when you design a trial, and that is that you may inadvertently recruit people who are much healthier than the background population because they're more interested in being part of a trial. So I think before we even can talk about endpoints and what's our potential to detect a difference in lung cancer incidence if we do one screening or we do 5 screens, we have to decide on what patient population we're going to have. then we can start projecting the number of cases, and then we can figure out what monitoring we would need to have to have a good expectation of detecting those cases. So I kind of feel like we need to talk more about those earlier stages in the trial than we have so far.
Thanks, Andrea. Definitely, we will have to address that question, whether this is an open, we will have selection bias or entry biases, all that stuff we'll have to address. And as far as liver fat, we decided to not put it as an endpoint, but as you said, when CT detects moderate severe steatosis, and those people will be routed towards the FIP or whatever guidelines that we have in place. Thank you.
Yeah, it's very simple. Yeah.
Thanks, Andrea. I'm going to go
Sure.
to Bob Kloner. Bob, can you, I couldn't hear you last time. Bob, can you hear us? You're muted.
Can you hear me?
Oh, yes. Perfect.
You can.
Bob,
Okay.
would you like to weigh in?
Yeah, well, I think this has been a great discussion. I think that one of the concerns that I had, which has been raised, is the issue of crossover. That is, people in the control arm going and getting, CT scans now, especially with the new guidelines. But I think David raised a really, potential solution to that, and that is, if you have participants now who are going to be in the control arm, who are going to get a CT scan, you'll almost be looking at then those who get a CT scan in the control arm suggested by their physician versus those who have repeat scans in a systematic fashion. And so that may become really sort of a second question that you're going to ask, and that might help solve this whole, or to some extent, the crossover problem. I like the idea of this a virtual clinic for the control group, but then again, if it's going to be based on sort of the standard guidelines that are out there, and these guidelines has been described are a moving target, you have to have those standard guidelines in both groups. And then it may be that, again, that the calcium that's seen in the CT scans is going to change to some extent the therapy, and maybe it'll be or maybe the compliance. And then I think that's another issue that should be raised, and that is the assessment of compliance. How is compliance going to be monitored in both groups? And is it going to be the same, or is it going to be different? So for those who get to see their CT scan and they see the calcium in the coronaries, will they be more compliant with their medicine? Will they stay on the statins rather than start the statins and then drop the statins, as many patients do, as you know? I think Peter raised a very good question about incidental findings. But look, those are always going to occur whenever you're doing any kind of imaging study. And we deal with that in some of the recent brain aging studies we have. It's just, it's going to be an issue no matter what you do. If you're doing imaging, you're going to have incidental findings, and you'll have to deal with that. So those are my thoughts.
Great. Thank you for a good summary, Bob. You kind of touched A to Z of the issues that were brought up. We will have to dig deep in all of these items. We can't, get to a clear picture right now. But I think the main point that we came up tonight is that in order for this trial to work, to get IRB approval and to be a meaningful trial, we have to make sure that the control group is treated as a standard of care, but not as a poor quality care delivery. That's
exactly.
We have
absolutely,
to. Yeah, and we will work on that. I'm going to go to one place in this room who is from pharma, my friend Mike Jameson. He doesn't represent Pfizer here. He's here because he's my friend, and we haven't seen each other for a long time. But Mike, you've been in this field for now 30 years, and you've been in so many trials, and your pharma world, what they are interested in. And Paul Ritker said something that whoever said that pharma may not fund something that is in both arms. But what we know is the imaging arm will get more intensive therapy. So if they both get a statin, one get more intensive a statin or PCSK9, whereas the non-imaging does not get. Let's hear your thoughts, please.
Okay, thanks, Mort. So let me share experience from the SHAPE recommendations that we made, and we tried to get funding from pharma for that. And we came under some criticism in the press. I don't know if you remember the Boston Globe. And the idea was that although this was a good thing to do and it raised all the boats in the water and everybody got better care, it was the concept that pharma was pushing something that would help to drive prescription, selfishly drive prescriptions, not just in an insured population, but like here in a Medicare population. So that's always tough. So that's why pharma didn't fund SHAPE, because we felt concerned that we'd be criticized for trying to drive prescriptions. That's one thing. The other thing is that pharma, to be honest, it's not altruistic. Pharma wants to see return on investment, and that would be one of my questions is what would the return be for pharma from this other than to drive prescriptions? I say not altruistic. That doesn't mean to say pharma doesn't fund good science that doesn't really drive prescribing, but it's tougher. It's a tougher sell for pharma.
I think Bob Kloner published a paper on your answer is what is in there for pharma. If the image-guided treatment would get more expensive medication and tailor it to a more at-risk population. That's basically as the foundation. So he and Matt Buddha published on PCSK9 according to CAC versus PCSK9 for the entire population is not current, standard of care. So you will have a standard of care or new arm in the research group that gets more intensive, more expensive treatment. PCSK9 is one, SGLT2 inhibitors another for those with pre-heart failure, large chambers, and so on. So that would be the path for pharma to see a return and do good, because those people will benefit from, and otherwise they're not getting treatment. They're not getting these kind of treatments. Today, somebody with enlarged LA just keeps going on until they have a stroke. That's all they do.
Yeah. So another comment is that it's a 5-year trial that takes some time to design and set up, and then it's with a 5-year extension. So treatment is going to change enormously in that. Even the use of the GLP-1 RAs in obese patients, including patients who don't have any CV risk factors. And so that might, a huge explosion in the use of GLP-1 RAs for obesity may swamp the effects of your intervention if everybody is now taking loads and loads of these pills as they become more affordable. There are oral versions coming along.
I want to connect your point and Peter Libby and the thought that it's a moving target. A lot of things are added, but look at the reality. About like 5 to 10% of people are getting primary prevention. Majority of people are not getting primary prevention, even though we have treatments or new guidelines are expanding, but we're not reaching people. And this is a cardiovascular. In lung cancer is even worse than this. It used to be 3% would get lung cancer screening. Now, after whatever 10, 15 years, it's between 15 to 17%, the latest that I heard from David's group. So even though there is treatment and guidelines is improving and all that, advancement in drug therapies, people are not getting it. We're not delivering primary prevention. Everybody comes in when they have symptoms. And so that's what we're trying to do, to shift the paradigm, to go get those people put them on treatment, identify them early. And so without imaging, we can't do it. Without imaging, we're bound to the same thing we had 30, 40 years ago. Just go measure your cholesterol or do these risk calculator and then see what comes out. So that's really is we have to. So I think Don Lloyd emailed all of us and said about, the essential 8 and all the, fantastic outcomes they have, but they're only 3 to 5% of the population. And so we need to get out, and how to get out, that's what this, go ahead, Mike.
Yeah, you and I agree, right? So we agreed back in the days of SHAPE that to do CACs in certain patients without looking at risk factors was a good thing to do. I'm just sort of suggesting that people within pharma have a different mindset, and just to be careful to bear that in mind as you approach pharma. Happy to advise.
Thanks. Yeah, I'm going to go at the end to Caitlin, who's from Susan Just Foundation, to give some thoughts and introduction about the organization. Nathan, we didn't hear from you. Can you, Marlon? Dr. Wong.
Yeah, no, I think, and I'll just start off by saying that, I echo Dan's first, remark that, you would never be accused of not being ambitious. It's a seriously ambitious trial. I think many of the comments, that I agree with have already been made. I want to kind of, reemphasize a point that, it's critically important that we agree on the inclusion criteria, right? Who's going to be included, right? Is this going to be Medicare people, or is it going to be a wider range? I agree with Martha that, we might have a missed opportunity if we don't include younger people, but the actually distribution of age, and, if we're going to have, certain proportion targeted within each age group, that's as well as other inclusion criteria, right? In terms of, are we going to specifically target, maybe at least intermediate risk people, right? That's going to, largely dictate the sample size and the power. It will have downstream effects on the cost of the study. So, and I think certainly the, we have to agree on whether, we're going to be doing annual scanning versus perhaps every other year or every 3 years. And I'd be curious, is there that much incremental value towards doing annual scanning versus maybe every other year? So, because that's going to have a big impact on the costs. And I think, we've had a lot of discussion about the control group. I agree that there's going to be some drop in, in terms of people getting scans in the control group and perhaps starting statin therapy. But I think it's going to be probably modest compared to the intervention that is being proposed in the intervention group. And then, as far as, if you blow up the, the interventions in the intervention group, certainly, we might want to modify that according to the new guidelines, especially with CAC.
Yeah, this is not final.
Yeah, and I agree with the point about using probably, I would say, a combination of the absolute scores as well as a percentile, like what the guidelines have, right?
Yep.
They have both, it's kind of either or. Yep. And then certainly, we don't have good consensus on whether, people in the highest quartile of these other measures should be treated and with what, right?
Yep.
So that needs to be further elucidated, because that's going to be a lot of people, right? If you want to give GLP-1 receptor agonists to like 25% of this group, or SGLT2s, there's going to be a lot of cost.
Yeah, but this is again, yeah.
So, I think those were some of my main comments. I think the point about, the treatments that will be given in the control group, it's a moving target, as was pointed out by actually Dr. Libby. But still, as we know, it takes 15 years or more for guidelines to get adequately implemented. We still haven't seen good adherence just from even the 2018 and the 2013 guidelines. So, there's still poor adherence out there despite these recommendations that have been out for more than a decade. So.
Thanks, Nathan. John Osborne, let's hear your thoughts, please.
The biggest challenge is the evolution of therapeutics is going to be the biggest challenge. I mean, we're setting out very aggressive goals, which I think is 100% on target, using multimodalities, lipids, GLP-1s, glycemic, if you will, all of those things. I think the challenge, particularly the trial this big and this long, is going to be try to anticipate where we're going to be therapeutically in the mainstream, right? I mean, there will always be those around the table that we're always, at the bleeding edge or leading edge. But where the mainstream is going to be, it's the way approach to science. Go where the puck is going to be, not where the puck is. And I think that's the big challenge. That's not really an answer to you, but I think that's the theme that I would really be very, very cognizant of.
Yep. Thanks, John. So, yes, I want to go to Jim Molshine at the end to wrap up our meeting. So, Jim, if you can bear with me for a few minutes, I would like to have a couple of minutes of intro. Caitlin, are you still there? So, the Susan Wojcicki Foundation that I mentioned is the the poster child of what we're trying to accomplish, with Susan being poster child of that organization and the cause that they're pursuing. Can you please, I see Caitlin is back on, can you please tell us briefly, most people don't know Susan, if you can just please give a couple of minutes of introduction to your organization.
Yeah, absolutely. Thanks for having us, folks. I'm joined by my colleague, Pat Ahrensdorf, who's a consultant for us, who has had a long career in early detection and is helping us with some of our mission to improve early detection technology and expand screening guidelines in lung cancer. As Mort mentioned, and some of you may be aware, Susan was, Google was actually started in her garage. She was one of the first employees of Google and was the CEO of YouTube, and was diagnosed with stage 4 HER2 positive non-small cell lung cancer at the age of 54. 5 kids, a loving family, and tragically Susan passed away at the age of 56. I came over to help the family with some of their lung cancer philanthropy and worked closely with Susan along with my colleague, the executive director of the organization, Nadia Litterman, focused at that time on therapeutic research and characterizing lung cancer in people without a history of smoking. But after Susan's passing, the family decided to pivot to really focus on, as I mentioned, improving early detection technology, expanding screening guidelines, and advancing preventive interventions like cancer vaccines and chemo prevention. So we're a new 501c3 carrying on our previous lung cancer work for the last 2.5 to 3 years, but we'll be launching publicly in May, and are excited to continue to learn from and work with the community to understand the best ways to expand lung cancer screening to save more lives of people like Susan.
Thanks, Caitlin. So, David?
Yes.
Just to derail things a little bit, as I have been listening, thinking about this, we don't really, could this be a trial of screening for non-tobacco related lung cancer as the primary?
We're getting a lot of echo, Mort. It's hard to hear it, David.
Yeah. So could this be a screening, a non-tobacco related screening trial for non-tobacco related lung cancer? That the idea underlying all of this is, should we be doing low-dose CT on everybody at a certain age? You've heard a lot of critique about how ambitious this is, how complicated it is, and with the heart-lung analyses, we're picking up all of these different incidental or opportunistic findings and approaching lung, heart, liver, bone. It gets a little diffuse and a little overwhelming or confusing. What if it was just low-dose CT screening for lung cancer, but doing annual, if that's the right frequency, and maybe based on what we know, choosing the population that's at highest risk for non-tobacco related lung cancer, or just all comers ages 50 to 80. You could then, you will have all the information about the liver, the lung, the heart, chamber sizes, and you could see if providing that information without dictating drugs, see if that makes a difference in therapy. You can provide the images and the observational data that you already have for heart-lung analyses and see if the therapy selected by the physician results in a reduced incidence of heart failure, atrial fibrillation, et cetera, without being so heavy-handed with the drug therapy. So that's a completely different perspective and probably unsettling. And maybe it's not a good idea, but I just thought I had to say it.
Sorry, not everybody can see who is talking. You guys online only see Marlon's name because it's connected to his computer. But David Marin was suggesting if a modified version of this and simplified version of this would work. I think we're just going to come back to the bottom, to the beginning, where we, prompted all of these is that we want to make a difference in primary prevention. Our primary prevention is broken, and how to fix it requires a new strategy. Just doing the same thing the old-fashioned way, or doing it in a more fancier way, is not going to get us to where we want, because we have seen that over the last 30, 40 years. And just doing the trial, the Danish or Scandinavian colleagues style is not really going to work, because if we just send a letter out to go get the screen, or just get a screen and not actively work on delivering care through, AI. Now, agentic AI is coming. We are in a new world now. We should try to leverage the new world and break the back of the statistics that we're stuck with for 30 years, 40 years. So that's the premise of this. And I invited Caitlin to introduce, because this is just high-level talk. David, Nathan, and I, we had a meeting with them, and we would like to propose to their foundation to be the lead organization for this trial. And we go to our page, with all these things worked out, details, because our approach has a very methodical. So I'm going to just wrap up and then go to Jim Molshine, and that is, over the next 6 months, we plan to formalize the design and everything, and go to ARPA-H. If I think everybody agrees, if funding was there, we would pay the treatment for both groups. We do everything that ideally you would want to do. This trial is worth doing, and can solve our problem in terms of not knowing. And I think David Yankeliewicz's proposal of doing annual, because the dose is not an issue, and if funding is not an issue, then it will just give us tremendous amount of insight into what the future proper preventive health should be. So with that, again, there is no commitment from the Susan Foundation. It's just a talk of high level that we thought that their organization just perfectly symbolized what we're going after. And if they take the lead, and all the academic institutions that are here and others who are not here would rally behind them, and we go to raise fund, in nonprofit organizations also are there for funding. So with that, Jim Molshine, are you still there? Oh, Jim is,
yes, I am.
Jim, are you there?
Yeah, I am.
Sorry, Jim, we can't hear you. Okay, great. Yes.
Okay. Mort, okay, quickly. I appreciate David Marin's comments, but we got to understand that 80 to 90% of lung cancer is tobacco related. There's a lot of other things contribute to that, but that's what it is. Cardiovascular disease, there's a similar problem of a high causality or relationship to tobacco related disease. However, Mort, you showed an early slide that coronary calcium predicts lung cancer. We think about lung cancer as kind of an inflammatory disease, and we also think about it as, yeah.
Jim, can you, your audio is muffled. We can't.
Okay.
Yeah.
Does that work better?
Much better.
Okay. So I'm sorry, Mort. We think about lung cancer as a inflammatory disease. We think about it as a metabolic disease. Progressively in cardiovascular circles, I think there's a similar thing going on with an inflammatory related disease, host immune response disease, as well as a metabolic disease. And I think if we think about these things as not opportunistic type of stuff, but rather comorbidities in a major chronic disease environment, I think we can get a much better story for patient-centric or screening-centric participation in this prevention trial. And, many people have commented on the issues of sample size and contamination and this, that, and the other thing. And I think that has to be considered, and I'm sure you'll go back and, as Andrea suggested, do the modeling and stuff like that to sort that out. But one of the things you could simplify to allow for, some kind of meaningful endpoint is that you have to also understand that a coronary calcium scan also is a lung cancer screening study, and a lung cancer screening study is a coronary calcium scan. And you have to sort out that kind of overlap in terms of how you're going to report these things in these different populations, to do it in a systematic way so that you wind up with clean endpoints, as opposed to this muddied thing about some places gave this kind of report and that kind of place gave another kind of report from either of these scans. These scans are so powerful and have so much information. Like you say, Mort, it's a new world. And I think if you attend to this up front and have some standardization and buy-in from ethics and all that other stuff, it can greatly improve the dynamics of the trial. And it's very ambitious to do this, but it's also a major fraction of the burden of disease in this country, and I think that has to be emphasized. And if
Thanks,
you do,
Jim.
I think you're
Yeah,
fine.
Jim, I think you obviously lived this life, and you and David and Claudia that I've met are actually doing this, both lung and cardiovascular, screening. But your population is, by definition, is smaller, much smaller than the cardiology world and the cardiovascular world. And we have now an opportunity to bridge these two. And as I said at the beginning, the meeting that we had 2 years ago in New York really opened the door for this trial to be now discussed for a second time. And I'm hoping over the next 6 months, we'll bring it down to a level of granularity that would be meaningful for all of us to put our name and efforts behind it to go get funding. And if we get funding, I think all of these questions will be answered, and we will pave the way for whatever the future will be. And we have to keep in mind that we're at the transition point with AI that inevitably is going to affect whatever else we want to do. So we have to keep that in mind. I want to go around the room, see if there's anybody else that I have not invited and is interested to weigh in. We're at the end of our meeting. I think we've covered David.
Yeah, I just had one comment to make. I think the whole basis of this, as you stated, is that the imaging or sort of phenotypic representation of disease is going to be the most powerful, more powerful than any other traditional sort of risk marker. I think ultimately that's what we're saying, and that's what we're hoping to prove. For doing a trial like this, the big expense or the major expense in this is the long-term follow-up. And that's where you're hearing the concerns about, well, treatment will change because this could take 10 years, and what we start with as treatment is going to be totally different. So these are all real concerns. So to me, the only question that we have to be firm on is whether or not we go the full distance and say, yes, we want to prove mortality reduction with long-term follow-up. Or do you want to do something a little bit like David Marin said, although I have a slightly different view? You could get all of the sort of diagnostic information that you need in 2 or 3 years, and then rely on sort of secondary endpoints. To me, that's the main decision node, because then the trial expense would be much lower. You don't have to worry about many of these other things. To me, that's the only consideration. I'm not saying I'm preferring one over the other. I'd love the idea of doing long-term and getting all these outcome data. But if you're willing to accept more secondary kind of endpoints, then you could finish this trial in 3 years at much, much lower expense. So to me, those are your considerations.
Thanks, David. As you said, to run a study like this, an ambitious goal like this, we have to get what we're investing in worth it. That whatever we're going after has to be something that is going to make a difference, not just add a little bit of information, some incremental knowledge. So I think the main point that we need to settle at the end is the study design with the intervention and control group, if done properly with sufficient capital, so on, is it going to show a meaningful outcome? That's the most important thing. And I think with the composite endpoints that we put in here, we have a good chance. But then the next immediate question is treatment. How intensive you're going to treat this group. That will define, according to Paul Ritker, if 30-40% of the control arm is on a statin, you're doomed. You're not going to get any result because that group is going to get significant. I'm not sure all of these are clear, but we will answer all of those over the next 90 days to 6 months by communicating with you guys. I want to thank everybody for joining us. Is there anybody who wants to say something that I did not invite? Because I can't see everybody on my screen. So without anyone else raising hands, I'm going to conclude our meeting with deep gratitude to all of you who shared your time, your brain, your passion for this cause. This is a cause that we all want to be proud of by making a difference in our future. So we will have follow-up discussions. As I gave you a quick update, I'm actively pursuing the CMS path to get CAC covered over the next 6 months. Our goal is before AHA, we have attempted our proposal to ARPA-H, and we'll see what we'll find out. In that AHA, we'll meet again, and we'll update you with where we are. Thanks again, everyone online. Thank you guys for staying at home, listening to us. Thank you so much. Have a good night, everybody.
Thanks, Mort. Great job.
Thank you. Thank
Take
you,
care.
guys.
Bye.
Bye-bye.
Bye-bye.